Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluation. And if you could, please give us any ideas you might have in regards to future topics or future speakers. Also, a quick reminder that next Wednesday we will not be convening for Grand Rounds, but we'll get back together the Wednesday after that. Today, I have the pleasure of introducing Dr. Jennifer Cruz. Dr. Groos is a pediatrician. She attended medical school at the University of Iowa and then did her pediatric residency at the University of Wisconsin. She currently is on the staff at Blank Children's Hospital, where she's a member of the teaching faculty and also a member of the adjunct faculty at the University of Iowa. She's been very active in the area of childhood obesity, and we're pleased that she was able to join us today to update us on the 5210 program. And please join me in welcoming Dr. Jennifer Cruz.
Thank you so much. Thank you. Well, thanks for being here today and for the invitation to join you. I usually like to start by just getting a sense of who all is in the audience. So how many of you are nurses and dietitians and any providers? Great. Any community members? Great. Sounds good. And thanks for the folks that are joining us online as well. So just to give you a little bit of my background and my interest in this area, I've been a pediatrician at Blank for about 14 years, and so during that time I've seen firsthand increasing numbers of patients walking through my doors that are affected by this issue, and so that's really been the drive behind my involvement. When we first started learning more about this, there wasn't a lot of good research about what we can and should be doing, but that research is now here, and so I'm excited to be able to share that information with you. So I'm the past president of the Iowa chapter of the American Academy of Pediatrics and have had the opportunity to work at the national AAP level with the section on obesity. They have a program called the Coaches Network, which is a network of providers across the country that are interested in this topic. And that's been a great opportunity as well. So just to give you an overview, I usually talk pretty fast, and so they've got handouts that go with this, but there's a lot of information I just want to touch on today to give you an overview of the extent of what we can and should be doing and the opportunities and resources that might help you in your practice. So we'll start by reviewing the epidemiology of childhood obesity and then touch on the importance of identifying and minimizing the impact that weight stigma has on the patients that we interact with. We'll move on to best practices around prevention, assessment, and treatment of childhood obesity in the primary care setting, as well as touching on the importance of utilizing motivational interviewing and brief action planning in our interactions with our patients. And then to give you a broad overview of the multi-sector approach to childhood obesity, the 5210 Healthy Choices Count program that's going on across our state, and then provide you with some resources. So just as some statistics, you know, about 2/3 of Iowans have overweight or obesity, and about 1/3 of Iowans have obesity. That places us about 13th in the nation. And as far as the youth in our state, about 1/3 of the children that we see have overweight or obesity, and about half of those, or 15%, have obesity, and that places us about 21st in the nation. And so we know that it affects all children, but disproportionately affects minority children. And so you can see in this graph that Hispanic children and non-Hispanic Black children are affected more so than white children. About 24% of Black children and 21% of Hispanic children from this data are affected by overweight and actually obesity. And we know that obesity itself is continuing to be a more and more significant problem. But this data recently was published in Pediatrics in March of this year. And you can see the bottom two lines here. This is class 1 obesity. So that's a child with a BMI greater than the 95th percentile. And then class 2 and class 3 obesity is the severe obesity. So this is 120% of the 95th percentile and 140% of the 95th percentile. We know that the comorbidities for these groups of children are exponentially higher, and we can see that these rates of severe obesity are increasing as well. So in 2013, the AMA adopted a policy that recognized obesity as a chronic disease state. we all know that it's a complex disease condition mediated by the interplay of multiple factors, from genetic and biologic to social, economic, and cultural determinants. And it's currently the most prevalent chronic disease of childhood. I think that's something that we don't always recognize. It affects about 12.7 million children in our state, in our country, and that's twice the rates of asthma. And so we know that there are a lot of factors that influence the likelihood that a child will develop obesity. We know that there are some intrinsic factors to that child, so genetics, age, gender, the intrauterine environment. We know a lot of those children that are SGA at birth are at increased risk of developing obesity as they grow older. We know rapid early weight gain and race all play a role. But beyond that, we know that the family environment that these children grow up in plays a big role in the likelihood of developing overweight or obesity. The parental weight status, the parental lifestyle, as well as exposure to ACEs, adverse childhood experiences, have a large impact on their likelihood of developing obesity, as well as the community in which these children and families are growing up in. So the school environment, the availability of access to healthy foods, as well as active opportunities for active living, all play a huge role. So we know that what factors are really contributing to this rise in overweight and obesity of children and adults in our country. And these are some of the factors that have been identified through research. So we know that there's a lack of access to affordable fruits and vegetables, expensive pricing of health foods, less time available for meal planning or to cook, as well as increasing portion sizes, especially in our restaurants, limited park and recreation opportunities, and proliferation of poor quality and energy-dense foods, sedentary work and school environments, as well as increasing amounts of screen time. And I hear you have an upcoming talk about gaming disorders, and so that'll be an interesting talk coming up as well. And limited knowledge and skills about food, cooking, and activity. And so what are the medical complications of obesity for children? So when I went through medical school, many of these diseases we rarely saw in children. But I now commonly in my office see children with elevated lipid levels, type 2 diabetes or prediabetes, as well as liver disease. Many children have elevated ALT levels and have early stages or stages of fatty liver disease or non-alcoholic steatohepatitis. And that's rapidly becoming the number one cause of liver transplant in our country, with advances in therapies for hepatitis C. This non-alcoholic fatty liver disease is progressing to end-stage renal disease or end-stage liver disease requiring transplant. Sleep apnea is a common issue encountered in children with obesity, as well as high blood pressure. Furthermore, there's social and self-esteem issues that surround obesity, sleep disturbances and sleep apnea that was mentioned before, and orthopedic problems. So these are more commonly being seen in children. And the other fact is that these diseases, when they develop in children, are much more aggressive than when they develop in adults. So we know that a child diagnosed with type 2 diabetes has an increased risk of advancing to end-stage liver or end-stage renal disease much more commonly than adults do. And then the complications of obesity for adults. We know that the 3 leading causes of death in our country, the risk of those conditions is increased by having overweight or obesity. And we know that children and adolescents with obesity have a 70 to 80% chance of having overweight or obesity as adults. So this is a disease, a chronic medical condition. It starts in childhood and progresses onto adulthood and is associated with multiple comorbidities. And beyond the medical complications, we know that there are huge economic costs. The estimate is $190 billion is the annual cost of obesity-related illnesses in our country. That's about 21% of the annual medical spending is on obesity-related illness. And a Brookings Institute report reported that if the 12.7 million children and adolescents with obesity in our country, they will likely have a lifetime societal cost of close to $1.1 trillion, with an average individual cost of about $92,000 in their adulthood. So that's a little bit of a background on the statistics behind the issue of obesity, specifically in childhood obesity. I want to move on to talking about weight stigma and weight bias. So how many of you are familiar with weight stigma? A whole lot. So we know that many diseases have a stigma associated with them, and that we know that many times this stigma is not only in the healthcare setting, but in multiple settings throughout a person's experience. So we know that disease stigma affects health and a person's health and personal and social, educational, and professional achievement. And it's a barrier to prevention, intervention, and treatment. And so we've learned from other examples, such as HIV and AIDS and various cancers, alcoholism, and drug use, that we have to acknowledge the impact of disease stigma before we can make progress in prevention, intervention, and treatment. And so weight stigma and the stigma associated with obesity and overweight is no different. So to this end, the American Academy of Pediatrics published a policy statement last fall acknowledging and reviewing the impact of stigma associated with or experienced by children and adolescents with obesity. And so it gives a good overview of the issue, the research behind it, and recommendations on what we can and should be doing in our clinics and in our communities at large to address this issue and minimize the impact that it's having on our patients. So weight stigma is a societal devaluation of a person because he or she has overweight or obesity. It's associated with the stereotypes that can be associated with overweight or obesity, and these stereotypes lead to social rejection, prejudice, and discrimination. And it can be in the form of physical, verbal, or relational, and sometimes it can be subtle or oftentimes more overt. And so there's a false belief that stigma and shame can motivate behavior change. And so, and when in fact, it actually worsens the issue. It leads to binge eating and avoidance of healthcare, and then that in turn worsens the condition, and the cycle perpetuates itself. So we know that patients with obesity may experience stigma in the healthcare setting. We know that they're exposed to that more commonly because of the medical conditions that they may encounter because of the obesity. More bias leads to negative feelings and future avoidance, and then continued unhealthy behaviors and poor self-care worsening the issue. And so just wanted to touch on the importance of this issue. There's actually a training I'll mention later in the presentation for more resources. It's a 1-hour CME credit that's available on our IMS website if you'd like to learn more about what you can be doing in your clinic to acknowledge the stigma that is there and to minimize that. There are some changes in workflows and the language that we're using. And actually just today, the section on obesity has a new infographic out addressing this issue and has some great tips on it as well. So I'll hopefully be able to tweet that out later so you have access to that as well. So let's move on to prevention, assessment, and treatment of childhood obesity. And so hopefully when you came in, all of you picked up one of these pamphlets. This is the Iowa Clinician's Guide to Prevention, Assessment, and Treatment of Childhood Obesity. This was a project financed with SIM funding last year, and it was the work of the Iowa chapter of the American Academy of Pediatrics Committee on Obesity. And we pulled together pediatric specialists across the state to weigh in on this issue and review the most common or the most recent evidence on what we can and should be doing in our offices. And so this is just an overview of the data that was used to develop this. And we worked with the Iowa Department of Public Health, Iowa Medical Society, and the Family Practice Association in the state to push this information out and to all come together on endorsing this information so we're all on the same page. This is a screenshot of the Iowa Medical Society website. There's the URL at the bottom, and so you can see this is the link. You just click on this, and behind this, as well as downloadable versions, printable versions. So if you need extra copies, you can contact us at IMS as well. So this is the overview of what we can and should be doing. So in the green on the left-hand side, you can see the BMI. So for children with a BMI of the 5th to the 85th percentile, or the BMI of the 85th to the 95th percentile without risk factors, for these children it's recommended that we deliver a consistent evidence-based message regardless of their weight. So we know that even though a third of the children in our office that we see have overweight or obesity currently, another third of those will go on to develop that as adults. So even if they don't have the issue currently, it's important that we're assessing healthy behaviors on an annual basis at their well child visits and giving them targeted information to build healthy habits from a young age. If children are at the 85th to 95th percentile with risk factors, and those risk factors are listed in Table 2 in the brochure, or if they're 95th to 99th percentile or over the 99th percentile, it's recommended that we offer these families the opportunity to have stage 1 and stage 2 intervention in our primary care settings. We as primary care providers are the best poised to be able to help partner with these families in setting goals using motivational interviewing and brief action planning to change the behaviors of these families and children. And so it's recommended that we see them back at 3 to 6 months initially to be able to work through assessing their current behaviors, partnering with them to find out what changes they'd like to make, setting small goals around those and connecting them to community resources to help support those behavior changes, and then reassessing. Again, this is really important that we utilize the patient's readiness for change when we're doing this. If a patient isn't ready for change, us telling them or prescribing exercise is not going to do anything but put up more barriers to between us and our patients. And so that's why the next section about motivational interviewing is really important. So if stage 1, seeing them back every 3 to maybe 6 months, they're still having issues, they're not making much progress, it's recommended that we see them more frequently. So maybe every 3 months. Are there opportunities to engage other staff in our office? Is there a dietitian that's available or a care coordinator that can meet with that family, provide additional education? Or even just the discussion, the 15-minute discussion with us about setting goals and seeing them back more frequently. Sometimes that helps patients and families get motivated and continue their motivation for change. And then if things are not, they're not seeing improvement, they're still struggling with issues, then referring on to a stage 3 or stage 4 program. But this stage 1 and stage 2 is really important that we develop systems in our clinics to be able to help support our patients because, as I said, we're really, as primary care providers, best poised to be able to do this type of intervention. So when we're seeing those children over the 85th with risk factors or over the 95th percentile and above, the recommendation is that we take a careful medical history. We do an augmented family history, really assessing for those comorbidities that might predispose that child with obesity. And if they have family members with type 2 diabetes, we know that that child's risk is even higher. We do an augmented review of systems and augmented physical exam, looking for those comorbidities. There's a number of these children that are sick, and it's hard to, and we may be missing that. And so do they have prediabetes? And we know that that's a window of time that we can intervene with behavior changes and prevent them from getting diabetes. But if we're not looking for it, it's easy to miss. And then laboratory evaluation. So before I move on to laboratory evaluation, one of the topics that comes up is how do I do this? I mean, what are the billable diagnoses? And so we've worked with the Medicaid and the state as well as reached out to some of the private insurers. And obesity and their comorbidities should be billable diagnoses. And so our practice is to usually bill on those comorbidities. So if they have acanthosis, if they have fatigue or knee pain or foot pain, we'll code those highest. But if not, and if they just have obesity, coding obesity as a billable diagnosis should be covered. And so if you're doing that and you're getting denials from insurance companies, please email us, I'm the committee chair for their chapter, our state chapter of the Committee on Obesity, and we're collecting this so we can advocate at a broader level because we know that this is a chronic medical disease. We need to address it, approach it as we do other chronic medical diseases to be able to make an impact. Usually you can bill on time. This is a dot phrase that we developed. We use Epic at our system. Other systems have cut and pasted this into their systems to be able to more easily document the interventions that we're using in our clinic. So as far as the laboratory evaluation, for children 9 to 11, it's recommended that we're screening these children with non-fasting cholesterols. These are children that have normal BMIs. For kids over 10 years old, 85th to 95th percentile without risk factors, again, maybe just not only the non-fasting cholesterol, but perhaps consider a fasting lipid panel. If they've got risk factors, that's the recommendation that every 2 years we check a fasting lipid profile, a fasting glucose, and we consider an ALT, and do an ALT and consider an AST. And then if they're over the 95th percentile, it's that same set of labs, ALT, glucose, and fasting lipids. And then in this brochure on the back page on table 5, we went through this with the specialist and said, what are the cut points that we can use in primary care? What can we manage on our own and continue to follow? How frequently would you recommend we follow? And when should we be reaching out to you as subspecialists and referring these kids on? And this is the what everyone came together on. As far as billable diagnoses for lab evaluation, the CMS guidelines say that obesity is a billable diagnosis for the lipid panel, abnormal weight gains, a billable diagnosis for a glucose level, and for an ALT, they don't have specific guidelines, so I standardly use obesity or abnormal weight gain and haven't had kickbacks from insurance companies. We also reached out to Wellmark, and they said that all of this care should be covered under the majority of their plans. And again, if you have denials, please email me the journal information and the insurer so that we can advocate at a larger level on this issue. So when we're thinking about outcomes, it's important that we're emphasizing our concern for their health and focusing on behavior change rather than only weight. We know that there's a window of time for children where if we can impact their behavior changes, we can slow their weight gain, and with time they'll grow into their weight and their BMI can minimize. So that's a great opportunity for children, and so we can and should be taking advantage of that for these children. But also when we're talking about where they're at on the growth chart, it's really powerful to link that to the impact that that has on their health. So it's not so important that we label this child, your child is overweight or your child is obese. Both of those things add to the stigma that patients experience. So the recommendation is that we address the condition. And so if we are choosing to use those terms, we know that obesity and overweight both have a lot of negative connotations, stigma attached to them, and just using that language in the room with the patient can put up walls and draw defensiveness from the family. And so looking at the growth chart, asking them what their thoughts are on the growth chart before we delve in with our analysis of it, and then telling them about the link between the growth chart and their health and asking if they'd like that information. So asking permission before we're giving information, and acknowledging the link between the growth chart and the risk for health. And that's when we can actually make progress. Many families, if we talk to them about your child is obese, that's all they hear. It's an emotion-laden term. And so if we can link that growth chart to the risk of health conditions, they're usually more open to taking that next step in the discussion. So the link in focusing on their health, not only on their weight, acknowledging the difficulty in making lifestyle changes and provide support, and then recognizing that small weight loss or behavior changes can result in significant weight gains or health gains. And so we know that there's many children that may have an elevated BMI, and it may be very, very difficult for that child to move out of that elevated BMI range. But we know that if we increase the healthy foods that they're eating and we increase their activity level, or they see small weight loss as much as 10%, they can have significant decrease in the likelihood that they'll develop type 2 diabetes, they'll feel better, they'll have more energy. All of those are important. And so it's easy to get discouraged when we're not seeing movement on that chart, growth chart. And so acknowledging the progress that they're making in their behavior changes is really important. So stabilizing weight gain, weight loss, behavior change, and focusing on those healthier habits. And then oftentimes we'll see improved labs. So we'll see that HDL go up into a more normal range when they increase their exercise. We can see improvements in the triglycerides, ALT or glucoses with increased healthy habits. So it's more than just their weight that we're looking at. So moving on to motivational interviewing. So how many of you are familiar with motivational interviewing? So a lot of you. How many of you had kind of didactic training on that when you were going through school? So a lot. So we know that it's a preferred method of counseling for obesity management. It's client-centered or patient-centered directive method for enhancing intrinsic motivation to change by exploring and resolving ambivalence. So motivational interviewing is really for those families that really may not be ready for change. It's an opportunity to explore that ambivalence, weighing the pros and cons of change, and thinking through their positive and negative thoughts about the issue. And the goal is to facilitate a fully informed, internally motivated choices, and behavior change will follow. And so there's good research that actually even having the conversation about the pros and cons and reinforcing change talk will increase the likelihood that patients will make these changes. So Drs. Rolnick and Miller were the leading psychologists behind this technique, and it's really collaborative, goal-oriented method of communication, and it strengthens our patients' individual motivation, exploring their own arguments for change. And it's really a style as much as a technique, skill, or spirit. And there's some specific skills that we can use to be able to improve our using this technique in our clinical interactions. And so this is what I was mentioning, that studies show that allowing the patient the opportunity to advocate for their own change is predictive of their future behavior. But if we force or pressure people to make a decision about change, or we tell them they must, they really often argue for the status quo. But once we hear a patient verbalize an argument for change, and that act of them actually hearing themselves making that argument, that actually increases the likelihood that that behavior change will follow. And so this opportunity for patients to talk about why they want to change has proven benefits. So when I first learned about motivational interviewing, I thought, there's no way I have time to do this in a 15-minute clinic exam or office visit. And so the more I've learned about it and the more I've tried to implement it in my practice, it's really rewarding and it's beneficial. So the time that I spend with my patients is much better targeted. So if I'm giving them my 5-minute spiel on childhood obesity and healthy habits, I know that for most families, they put up a wall and they're not listening to a word I say. But if I engage in a conversation and I find out where they're at with the issue, what they've tried, and what their hopes are for change, and we work together on goal setting, and then I ask them what information they'd like, that time spent giving them that information is much better utilized than me giving them my generic spiel or my prescription to physical activity generically. So I think that I'd encourage you to learn more about it and to experiment with utilizing it. It's really hard to change the way we do things, at least for me it was, and so it takes time. So small steps. I usually pick out 1 or 2 skills that I'll try and work on for another month, then I'll come back to it and I'll try something different. And so it builds upon itself, but it's worth the effort. So just a comparison of usual practice. So usually the clinician sets the agenda, tells the patient what's important, and then we decide to move ahead with goals. We're responsible for the patient making those changes, and we're more of an instructor. And success is measured by the weight loss or the change in the physical measurements. But with motivational interviewing, it's really that patient that sets the agenda. They decide what's important and in line with their core beliefs and values, and they set the pace for that work. And they're responsible for if, what, and when the behavior change occurs. So we're there to partner with them. And we're not a failure if they don't make progress. We're a failure if we put up walls and aren't there to partner with them when they're ready for change. We're really there as a guide, and the success is measured by the patient's own values and goals. And so it's important that when we're addressing this issue that we're taking all of this into account, and that we're listening to the patients, we're utilizing motivational interviewing to help them determine next steps. And so that's, if they're not ready for change, that's when you're utilizing those motivational interviewing techniques. If they're ready for change and they're ready to take the next step, you still utilize those techniques, but there's a process called brief action planning that allows you to streamline that process, get them the information that they want. It's called brief action planning. It has good research behind it. And so there's a resource that we've developed that might be helpful for you in that. And then if the patient and family are not ready, respect that stage and let them know that it sounds like it's not a good time. It sounds like there's other issues that you're focusing on right now. Would you be willing to come back and readdress the issue or see where we're at in 3 months or 6 months, or are you really not ready for that? Give them that opportunity. That'll decrease your no-show rates for those follow-up visits. Let them be the driver of when they're ready for change. And they're much more likely the stage has been set for a much more productive visit the next time you see them. Oops. Okay, so Healthy Habits Toolkit. This was a toolkit that was developed recently in partnership with the Iowa Department of Public Health and AAP. The National AAP has a similar toolkit called Next Steps. It addresses some other topics, but these topics all align with the Healthy Habits Questionnaire that's utilized in the 5210 program. And so there's 9 topic-specific patient handouts, as well as a guide for how do I engage in conversation in a 15-minute office visit utilizing motivational and brief action planning. So this is just a screenshot of the patient handout and then the accompanying kind of guide about how do we address this issue with families, and then the resources that we can utilize as well. And so this is a spiral-bound toolkit that'll be available. So if you're interested in getting copies of this in your office, email us at IMS. It will be available on the 5210 website soon. So we know that the U.S. Preventive Task Force recommends that clinicians screen for obesity. There's good evidence in that, and that we should offer or refer them to more intensive behavioral interventions. But we know that to make big changes in weight loss, which is only one of the things we talked about, you need a lot of contact hours. So 26 contact hours or more over a period of 2 to 12 months. That's a lot of contact hours. We can't do that alone in our healthcare clinics. We need to partner with community resources. And so that's another part of 5210 that I'll talk about more. So we know we can't do this alone in our offices. How many of you are familiar with the 5210 message? Yeah, so it's a common evidence-based message to promote healthy eating and active living utilized across the country. It's a simple message backed by scientific evidence and endorsed by multiple associations. So it's used in Head Starts, AAP uses it, other settings use it as well. And it ties together the multiple messages that patients and families are hearing in our communities. So we know that there are a lot of messages promoting healthy eating and active living, but there's not one unifying message, and that's been shown to be more powerful. So the 5 refers to the 5 or more fruits and vegetables. The 2 refers to 2 hours or less of screen time. And on the right is listed all of the evidence behind that. The 1 refers to 1 hour or more physical activity. And 0 refers to the importance of 0 sugar sweetened beverages. And I do mention that there are recommendations around limiting the juice intake because we know that's an issue for many of the children in our country as well. And really focusing on the importance of using water as the best alternative to sugary beverages. But we know the 5210, many places, and excitingly now in our state, is more than a message, it's a multi-setting approach. We know that each of us in each of our different areas in the community can play a small role, but by working together we can really maximize the impact of our efforts. So there's the 5210 program in Iowa is based off of Maine's program. It's been in existence for about 10 years. It's called 5210 Let's Go. And it's a multi-setting model that allows us to reach childcare providers, schools, out-of-school programming like before and after care, healthcare practices, and unite all of us in the goal of encouraging children to adopt healthy habits that will really last a lifetime. And the goal is to change the environments, to make the healthiest choice the easiest choice. We know that oftentimes the healthiest choice isn't really an option at all, so we need to increase that opportunity for healthy choices, but to make it even easier than others. And so they provide toolkits and technical assistance to change policies and procedures. So it's more than just education, it's really the concerted effort to change policies in the environments that surround our children wherever they may be, in the schools, workplaces, when they see us in our offices, and in the communities at large, and the workplaces of their parents. So in Maine, the data shows that this is working. More than half of parents in their state are aware of the message. The sites that incorporate 5210, about 91% of them have eliminated or limited the sugary drinks and are providing water instead. Healthy behaviors are increasing with increased fruits and vegetable consumption. And Maine's childhood obesity rates are starting to decline in the data that they have, and that's not common in other places in the country. So this has really come together in Iowa in the last year or so. United Way of Central Iowa had been working on bringing this program at a local level to the Central Iowa, Polk County, Tri-County area, and they pulled together a group of stakeholders called Well Kids Coalition. At the same time, Healthiest State Initiative was doing something similar at a statewide level, and Iowa Department of Public Health was part of those conversations. And what came from all of these coalitions was the need for a common message and a common approach. And 5210 came to the top of the list. So in October, Governor Reynolds announced the launch of Healthy Choices Count. Gerd Klebaugh, the director of the Department of Public Health, was at the launch that was at Carver Elementary. They'd been doing some of the policy and environmental changes in that school for a number of years with United Way's help, and so it was great to be able to showcase some of the work and what this program really looks in action. And so the goal of Healthy Choices Count in Iowa is to permeate children's and families' environments with the message and provide strategies to support the 5210 behaviors to a variety of people and places. And so this is the landing page for the Healthy Estate Initiative /5210. It's where all of the resources are being housed. So you can sign up to be a champion. So all of us in whatever role we play can either impact not only what we do in our work setting, but also in our setting at large. So if you've got kids in schools, you can advocate for healthy choices at schools or in your community at large. And so these are some resources to help you do this. So this is just a screenshot of the posters that are produced, as well as social media assets that you can utilize if you're on social media. And you can download, and they have all other pre-prepared media materials that are free for people to use. And there's some just logo style guidelines, but otherwise we encourage you to utilize these and promote the message wherever you can. If you'd like to follow on Facebook, there's a website or a 5210 DSM, as well as some Twitter handles and the Pinterest page that has a lot of information about the efforts that are going on. And then this is the Healthy Estate Initiative. So under each of these pictures are the links for the tools. So Maine is really sharing with the tools and policy and support materials that they've developed. And so they allow us to rebrand that information and post it on our website for use in our state. So I encourage you to check out the website and click on whichever sector applies to you. The 10 strategies of success, the program really encourages limiting unhealthy choices for snacks and celebrations, limiting or eliminating sugary drinks, prohibiting use of food as a reward, giving ample opportunity for physical activity and recreational screen time, limiting that. And so that's where the child care and the schools, all of them are developing policies around these strategies. Additionally, they're encouraging everyone to participate in initiatives that support healthy eating and active living, engaging community partners, partnering with families to educate, as well as implementing staff wellness and collaborating with food nutrition programs. So these are the 10 strategies that across the multiple sectors folks are working together towards. So they're encouraging us to engage, become champions, to assess the environments in which we find ourselves, and then to create action plans around policy changes, system changes, and environmental changes. Oops. These are some of the resources. So they have a lot of great one-page resources on all of these topics that can be utilized in multiple sectors. So this is a screenshot of one of the handouts on 5 fruits and vegetables, and there's lots more where that came from, so check out the links to those. And then it's not only the media assets that were developed, but more targeted pilot programs across the state. So in 4 different communities, they had a small amount of funding that went to each of these communities to engage stakeholders in multiple sectors, and including healthcare, the community at large, as well as childcare. And so these were the 4 sites that were chosen for a 6-month pilot. So that went really well. For fiscal year 19, additional funding was allocated, and so now they're expanding this to additional 6 communities in 1 county to be able to continue this cross-sector work across the state with some support from IDPH. So I've been involved in the 5210 healthcare component of this. So United Way started this component. They wanted to partner with healthcare providers. So in 2017, we developed the 5210 healthcare program. It's really modeled exactly after Maine's because they had good evidence that it was working. It quickly spread across 5 health systems into 14 clinics in the central Iowa. Additional grant funding is allowing it to be spread through all of the UnityPoint Center clinics in central Iowa, as well as we're partnering with Mercy to be able to spread it through all of their clinics as well. And this has been with the support from Iowa Medical Society. They've been able to support this as a statewide and be able to support the IDPH funded sites. So it's a great opportunity to be able to partner with healthcare providers, not only within our health system, but across systems, across the state. It's not every day that we get an opportunity to do that, but with an issue as complex as childhood obesity, it's imperative that we do. So these are the counties that have registered healthcare clinics. So McFarland Pediatric Clinic here in town is one of their sites. In Marshalltown is another 5210 registered site, McFarland Clinic. So 5210 registered healthcare sites commit to working towards these 3 goals: connecting to their community by displaying the 5210 Healthy Choices Count posters, which we showed you earlier, accurately weighing and measuring patients and calculating and recording BMIs. All of us do that with our EMRs, but there are some best practices around it. It's not easy to measure pediatric patients, so there's a voluntary training if folks are interested. And then to have a respectful conversation around healthy eating and active living, utilizing the Healthy Habits Questionnaire. So this is the hardest part. It's a new questionnaire. It's not something that we don't collect patient data. It's a tool that clinics can use to be able to help routinely assess healthy eating and active living in their patients. And as far as the best practices, that's what's recommended. And so there's some support on how do I implement this? How do I implement this into my EHR, which we know is the most challenging in a lot of regards. So your register site, if you're working towards these 3 things and you've filled out your initial survey, so we can collect impact data. If you're achieve all 3 goals, they'll be recognized as a 5210 healthcare site of distinction. So this is the landing page for resources at the Iowa Medical Society. We have our childhood obesity toolkit posted there, as well as a link to the 5210 statewide resources. Additionally, there are a number of webinars that were based on what we were training people locally with at Des Moines, and we developed those into webinars so that everyone across the state would have access to it, and it'd be a little more accessible. They're available to be viewed by anyone, and you can get CME and CEU credits for free for those. So there's I think 6 hours of CEU credits available. And then this is the registered sites so far across the state. If you don't land on that page, you can get to Iowa Medical Society and hit resources, and then it's down here under childhood obesity. This is the Healthy Estate Initiative website, as well as the healthcare. So if you clicked on that healthcare setting, this is what you'll see. We've tried to make it easy for clinics to find the resources that they need. The Champion Toolkit, how to register your site. You can fill out the survey right there online, and then that gets all the information to Becca, and she gets the clinic signed up. And there's trainings. Those are the webinars, or if you'd like in-person trainings, that's available as well. And then a lot of clinics. So one of the pilot clinics wanted to promote the message in developing T-shirts, so their clinic did this on their own. And so Healthy Estate Initiative actually helped make it easier for other clinics to do it, design the T-shirts, and they're available on their website. This is a picture of folks from my clinic. We had our 5210 T-shirt day, and we do that regularly now, so it's a fun way to promote the message. These are the posters, and this is a screenshot of the surveys. And then these are the webinars. So there's the topics there's 2 of them just on general childhood obesity, and then there's one on accurately weighing and measuring patients, one on weight stigma, motivational interviewing and brief action planning, and then best practices around stage 1 and stage 2 in primary care. These are the resources that are available for 5210 clinics. And then a couple other resources that you can look for under the training on the website. Great resources if you're looking to improve your motivational interviewing, really clinic-specific, pediatric clinic-specific, or so check those out. So just wanted to finish up with some links to community resources, because I think that's the hardest thing to struggle with, is how do we know about the community resources and how do we effectively link our patients to them. So many schools will have programs. Kids Striders is a program that's available at schools in the metro area. There's similar programs across the state at schools where kids can record the number of laps they run at recess, or come in early, or stay after school to run and collect miles. But it's just a fun way to encourage increased levels of physical activity. So you can ask your patients, are those opportunities available at your school? Linking them to the YMCAs and recreational facilities in your community and partnering more closely with what they have available is a great opportunity as well. There's these programs called Girls on the Run and Let Me Run. Is that available in Ames yet? It's available in central Iowa and the metro area, the eastern part of the state. It's really been developed. So it's for kind of the upper elementary grades, and we know that as kids age, the physical activity levels of kids, especially if they're not excited about sports, really drops off. This is an opportunity to kind of fill that void for kids that may not be excited about sports, but like to partner with other kids in a social, non-competitive way. It also has some self-esteem building techniques as well, and curriculum as part of it. So it's Girls on the Run. They train for a little 5K over the course of several weeks, and they have a spring and a fall program. Let Me Run is kind of the analogous program for boys, and so these are great opportunities. And so if they're not in a community yet, there might be something similar, or you may see them soon. Partnering with your park and rec, they have a lot of great opportunities, and also partnering and advocating with them about healthy snack policies, and focusing on encouraging the participants in those programs to limit their sugary beverages like Gatorades and replace that with water. So that's an opportunity as a healthcare provider or parent that you can advocate as well. Hy-Vee Kids Fit is doing some great work across the state. They actually have a 5-week challenge that's been great. So some of those kids that stay home by themselves in the summer, I'll connect them with this. It has they have like a little workbook that they can download and has links to videos of exercises that they can do inside if they're not allowed to go outside when parents aren't home, and they can track their goals. So if you've got a motivated family and that seems like a good fit for their personalities, that's an opportunity that you, and some Hy-Vees are, if they complete this, they can bring the certificate in for a prize at Hy-Vee, but it depends on the local Hy-Vee. But it does align with the 5210 message. And has some great opportunities in education. And Buy, Eat, Live Healthy is an extension program that's available statewide. So it's a 9-session, I think they're an hour to 2 hours once a week. And so they encourage families to engage for the whole 9 weeks. They're available in Spanish. There is a requirement that half of the folks being trained have to have an income requirement. That they're lower income, but it's a free program and they have capacity to expand. So we've partnered and have fact sheets that I can fax referrals to the program if families are interested. And so Katie's the contact if you're interested in setting up that for your clinic as well. That's been well received and had a number of patients benefit from that. They also have an app called Spend Smart, Eat Smart. It talks about all the different vegetables, how you prepare them. Also has advice on how do you economically afford buying healthy foods, because we know that that can be a challenge at times. There are more and more programs to encourage kids to develop cooking skills. We know that there's a generation that doesn't know how to cook, and that contributes to less healthy eating patterns at times. And so getting kids excited about preparing their food, this is one such program in the metro area. And this is a national program called Dr. Yum. They have an app that you can download, and it has different, you can click on what's in your cupboard and it'll make you a little recipe, and it focuses on kids getting excited about healthy eating and trying new foods. They have a lot of great resources, so I encourage you to check that out as well. So those are just the URLs for the websites that I mentioned. This is also the United Way's website if you're interested in learning more. Screenshots of those. And that's the United Way webpage. The final thing were these food for thought. So AAP partnered with First 5 to develop a series of, they're really patient and family-centered. They're about 7 to 9 minute videos about understanding growth charts and picky eaters and raising a confident eater. Institute of Healthy Childhood Weight has some great opportunities as well. So I know we're getting short on time, but just gave you an overview of childhood obesity, talked about the importance of weight stigma, some best practices in motivational interviewing, as well as an overview of the 5210 program, additional resources. Thank you. Questions?
Great presentation. I just had a question. Is Maine watching to see whether adult obesity declines as the parents are there listening to all this? Is there any good adult?
They actually are developing an analogous program for the adults, and they're focusing on less prescriptive messaging, which is, I think it's eat real, feel better, move more. And Healthy Estate Initiative has kind of more adult-focused messaging at the same time, but there is ongoing work on partnering the two programs and watching rates in the adult population as well. Because we know that engaging the family is really the answer. If we're just targeting kids, we're not going to make progress. We need family change because kids don't have control over a lot of this.
In the 521 program, when someone says, "Oh, I'll just drink diet drinks," what do you say?
Yeah, so that's a good question. I think that the jury's still out on what the best thing to do is. I think it's all relative. If you've got a kiddo drinking 6 sodas a day, full sugar sodas, and they're an adolescent, I think that for those families, if they can envision themselves not drinking that soda, that it might be a small step in the right direction. But we know that the artificial sweeteners are intensely sweet. There's some data to suggest that perhaps that might increase their cravings for sweets later. And we do know that when you eat something very sweet and then you eat a fruit or vegetable that has different types of sugars, it tastes different. And so it affects the way other things taste. And so in general, I advise my patients to avoid that, avoid them if they can, but it may be a stepping stone for certain families.
Yes, your comment about people on food stamps have unhealthy lifestyles, and the fact that grocery stores that have moved into disadvantaged areas don't sell healthy food because people don't buy them,
Yeah.
suggests that if food stamps had a differential value, twice as valuable for fruits and vegetables, half the value for unhealthy foods, that it might change behavior.
And there are programs, there's a program called Double Up Food Bucks, and so SNAP recipients can get double the value of their food stamps if they utilize it at a farmer's market. So there's a number of farmers markets that are participating in this program in the state. It's called Double Up Food Bucks, and so you'll find more information about that on the Healthiest State Initiative. But you're right, it is hard. And there's some data about our health is really influenced by our zip code. And so we know that food deserts and lack of opportunities for physical activity really does play a role in our likelihood of unhealthy lifestyles.
I have a couple of quick questions, a question, a quick thought. I had a sociology professor tell me that Iowa is the state with the most obese white people in the United States. Have you heard that statistic?
I don't know if I've heard that one.
Anyway, so the other thing I just want to mention on the subject of diet drinks, Google NutraSweet and University of Iowa. Oh my Lord, they've got a study there talking about a 30% increase in cardiovascular mortality for people with 2 lousy cans a day of this stuff, and a 50% increase in overall mortality. I really don't know enough about this retrospective epidemiologic piece of work to defend it, but if it's off by a factor of 10, it's still way over the line. So just throwing it out there, I'm on a mission from God to discourage diet soda. I think you're better off with diabetes and obesity and what have you than you are with your NutraSweet.
Yeah, the jury's out. It's not been out that long, so that data is emerging, so we'll keep our eyes peeled. Any other questions? Thanks for your time and interest. Let me know if you have questions. There's my contact info.